Hello, welcome to AI Medical School. So Dr. Iris, what disease are we going to talk about today?
Today, we are going to talk about pneumonia.
So, let's to go the classroom.
Let's start our lecture. Pneumonia is defined as an inflammation of the substance of the lungs and is usually caused by bacteria. Pneumonia can be classified anatomically, such as lobar, affecting the whole of one lobe, and bronchopneumonia, affecting thallobules and bronchi, according to the setting where the infection was contracted, community versus hospital-acquired, or on the basis of etiology. Streptococcus pneumoniae, pneumococcus, is the commonest single cause. Mycobacterium tuberculosis is a cause of pneumonia and is considered separately, as both modes of presentation and treatment are different from the other pneumonias. In about 25% of patients, no organism is isolated. Pneumonia may also result from chemical causes, such as aspiration of vomit and radiotherapy. Clinical features. Symptoms and signs vary according to the infecting agent and to the immune state of the patient. Most commonly there is pyrexia, combined with respiratory symptoms such as cough, sputum production, pleurisy and dyspnea. Signs of consolidation and a pleural rub may be present. There may be a pleural effusion. Elderly patients often have fewer symptoms than younger patients, or may present with a confusional state. The severity of community-acquired pneumonia is assessed by clinical and laboratory criteria. Precipitating factors for pneumonia are underlying lung disease, smoking, alcohol abuse, immunosuppression and other chronic illnesses. The clinical history should inquire about contact with birds, possible psittacosis, and farm animals, Coxiella burnetii, causative organism of Q fever, recent stays in large hotels or institutions, Legionella pneumophila, chronic alcohol abuse, Mycobacterium tuberculosis, anaerobic organisms, intravenous drug abuse, S. aureus, M. tuberculosis, and contact with other patients with pneumonia. In this table, you can see the diagnosis of severe community-acquired pneumonia using CURB 65 and other criteria. CURBs stand for confusion, urea, respiratory rate, and blood pressure. And the minimum score is 1, and the maximum score is 6 for each of it. Investigations. Many otherwise fit patients with mild community-acquired pneumonia are treated as outpatients, and the only investigation needed is a chest X-ray. Patients admitted to the hospital require investigations to identify the cause and severity of pneumonia. Chest X-ray confirms the area of consolidation, but these changes may lag behind the clinical course. The chest X-ray is repeated at 6 weeks after the acute illness, and any persisting abnormalities suggest a bronchial abnormality, usually a carcinoma. The chest X-ray is repeated more frequently if the acute illness is not responding to treatment. Sputum for gram stain, culture and sensitivity tests. Blood tests. A white cell count above 15 × 10⁹ per liter suggests a bacterial infection. There may be lymphopenia with Legionella pneumonia. Marked red cell agglutination on the blood film suggests the presence of cold agglutinins, immunoglobulins that agglutinate red cells at 4 degrees centigrade, which are raised in 50% of patients with Mycoplasma pneumonia. Liver biochemistry may be non-specifically abnormal and serum electrolytes may show a raised urea and hyponatremia. Blood cultures are also taken. Serology. Some organisms, such as Mycoplasma, causing pneumonia can be diagnosed by detection of a raised IM antibody by immunofluorescent tests, or by a 4-fold rise in antibody titer from blood taken early in the clinical course and 10 to 14 days later. Arterial blood gases. The partial pressure of carbon dioxide in arterial blood rising indicates severe pneumonia. Urine is sent for Legionella and pneumococcal antigen testing in patients with indicators of severe pneumonia. Chest X-ray showing lobar pneumonia. There is an ill-defined area of opacity in the left lower zone without loss of volume, such as no shift of structures such as the mediastinum or trachea. The opacity is caused by the filling of alveolar spaces with fluid instead of air. Differential diagnosis. This includes pulmonary embolism, pulmonary edema, pulmonary hemorrhage, bronchial carcinoma, hypersensitivity pneumonitis and some types of diffuse parenchymal lung disease with acute onset. Management. Antibiotic treatment of community-acquired pneumonia is summarized in. In addition, pleuritic pain requires analgesia, and humidified oxygen is given if there is hypoxemia. Fluids are encouraged to avoid dehydration. Physiotherapy is needed to help and encourage the patient to cough. Patients with severe pneumonia should be assessed for management in the intensive care unit, ICU. Hospital-acquired nosocomial pneumonia occurs in patients who are beyond 2 days of their initial admission to the hospital, or who have been in a healthcare setting within the last 3 months, including nursing/residential homes. It is often due to infection with gram-negative organisms, and treatment is with coamoxiclav 625 mg 3 times daily, or in more severe cases second-generation cephalosporin, such as cefuroxime, and an aminoglycoside, such as gentamicin. Metronidazole is added in patients at risk of anaerobic infection, such as prolonged ICU stay or aspiration in a comatose patient. Antibiotic treatment in all cases is adjusted on the basis of the results of sputum microscopy and culture. Complications. Complications of pneumonia include lung abscess and empyema. We hope you liked today's class.
And don't forget to subscribe to our channel.
Thanks for watching.